invite everybody to our first session for this year, training to Tanzania, and it's going to be on postpartum hemorrhage, prevention of postpartum hemorrhage, and the area that we can address that specific before identification, managing, and after. And then how do we gather the help for this healthcare workers so they can address this patient who is experiencing postpartum hemorrhage. So on the call, I have a lot of people. That's great. So I'm gonna let you guys just introduce your name, and then so we know who is here, then we can have good discussion. So everybody knows who I am, so I don't have to. I'm just gonna try to moderate the discussion today. So a lot of stuff that we are planning today is to get what the current practice that they're doing in Tanzania, and then be able to share and see what the best practice is, and then focusing specifically for postpartum hemorrhage. Our goal for this meeting is to get those best practice and then start working behind the scene with the people who are involved, and then be able to implement when we, people should implement before we get there, and then when we get there, we can continue doing those stuff. So it's exciting stuff to have a lot of people who came in today, and thank you very much for spending part of your Saturday with us. So I am gonna let everybody just 5-10 seconds introduce yourself, starting with our very Vice President, Mr. Siakabe. I know you're on the road, but.
Yes, I'm here. Good morning, everybody. Glad to see you all. Glad to see you, Dr. Ngito. It's been a while. I'm on the road, so excuse my my situation. But good morning, good afternoon, and look forward to a great meeting. Asante sana.
Thank you, Dr. Tilia.
Good morning, everybody. Good morning, good afternoon also. I'm Robert Tilia from Tanzania. I've been working in a program called Newborn Essential Solutions and Technologies. But before that, I've been also working on the projects which were dealing with the improving care to pregnant women. So I find a link that you cannot separate newborns and women. That's why I'm still interested to work in both, or to collaborate with the others working in the other side, so that I know the product will come to our program. So we don't want to have this product because we are working with the sick babies and we don't want them to fall sick. So in that case, we have to combine our efforts helping mothers so that these babies will be safe. Thank you.
Thank you very much. Dr. Tilia, also, we know him as our NSG guru. And he helped us last year on the medical mission, and then also he allow us to go the NSG. So thank you very much, and we're going to continue working with you and to improve the care in Tanzania. So thank you.
Thank you.
Okay, Alisa.
Good morning. My name is Alyssa. I'm a nursing student at South University, and I'm glad to be joining you all.
And Alisa will be coming with me to Tanzania for the medical mission. So we are so excited. Thank you, Alisa. Dr. Emma.
Hey, can you see me?
Yes.
Good morning, everybody, and good afternoon. It's wonderful to be here today. Dr. Emma Kulwa, and I am a native of Tanzania, but I was born in Kenya. Let me just be clear on all that. I did have a privilege of also living in Tanzania, especially in my teenage years, before I came to college here in America and then medical school. So currently I am a practicing obstetrician and gynecologist, and I have a private practice. I work with 3 other doctors, and also we have midwives. So we do quite a few numbers of deliveries, but I love my job. That's what keeps me going at 3 o'clock in the morning when we have to wake up to deliver those babies. But I'm also happy to be in this group, which is trying to improve healthcare for women around the world. So I'm happy to learn and to share what I know. Thanks for having me here.
No, thank you very much, Dr. Emma.
You're welcome.
Yes. Dr. Msambichaka. Dr. Msambichaka.
Sorry, technology issue. Couldn't find the button. Good morning. My name is Dr. Lillian Msambichaka. I am an internal medicine doctor and a pediatrician. I'm currently based in Delaware. I practice mostly in the hospital. I don't see patients outside of the hospital. I was on the medical mission with Qhsc last year, and I am looking forward to going again this year, mostly focusing on babies. I will leave the mothers to the capable hands of my obstetricians. Thank you for having me.
Thank you very much, Dr. Msambichaka. We have good news and exciting future plans for next year. Dr. Tilia is here, but we'll discuss that part later. Dr. Amibela, I think it's Amibela. Yes, we come back to her. Ms. Bree? No, I know she's working, but I just wanted her to say hi. But anyway, Ms. Bree, she is going to be one of the leading person to help with postpartum hemorrhage, this medical mission. Yeah, unfortunately, of course, healthcare workers. So she's working today, and right now for the nurses, is shift change report. So she might jump in a little bit later to say hi, but thank you, Bree, for everything you're doing. But you guys will see her later. Dr. Guido, I'm going to give you a few more seconds, Satis. I know you just say your name and then tell us what you do.
All right. Hey, guys. Good morning and good afternoon in Tanzania. My name is Dr. Fabian Guido. I'm a pediatrician and also pediatric hospital medicine provider. So basically my service is mostly just inpatient, caring for newborns, sick ones, and well babies, and also pediatric patients. And I'm glad to be part of the group and looking forward for exciting future.
Yes, thank you very much, Dr. Guido. Dr. Nestor?
Hello, my name is Nestor Qhsc.
Hi.
I am right now I'm in Lindi, so it's a little bit it can be a little bit of a network problem here because I'm a little bit outside town, so I'll be in town in maybe 20 minutes and then the connection is much better there. So I am a resident in obstetric and gynecology. I'm doing my resident in obstetric and gynecology in Sweden, Gothenburg Hospital, which is one of the largest university hospital in the Scandinavia countries. And so I used to work in the southern part of the country, Tanzania. I'm from here, I'm from Tanzania. So I used to work in Mtwara in Masasi district at a private hospital known as Ndanda, which is also a mission hospital and a private hospital. So right now I'll go there and I'll be there visiting the hospital, and I have 5 weeks vacation. So I'm here in Tanzania for 5 weeks now, and maybe I'm going to say hello to my former colleagues.
Thank you very much, Dr. Nestor. 5 weeks.
Yes.
Oh, my goodness.
Yes.
That's a very good work.
Thank you.
Thank you very much. And thank you everybody for here. Oh, Dr. Aminata, are you able to speak now?
Yes, hello everybody.
Hi.
Hello. So my name is Dr. Aminata. I'm currently working at Mwananyamala Regional Hospital here in Dar es Salaam. And I'm a medical doctor rotating in obstetric and gyne department. So I'm glad to join you in this discussion and hope to learn much more from this discussion. Thank you.
Thank you very much. Yes, we're looking forward to your feedback and for everybody else. Elma, do you want to say anything? Hi.
Hi, sorry, I don't know how to use this that good, but I'm just happy to be here and hoping to learn something and look forward to see what else you guys are discussing here.
Yeah, so Emma is one of my students. I'm trying to convince her to be labor and delivery nurse. If not, then she needs to be baby nurse. So I'm working on it. Okay, thank you guys. Thank you everybody for being here. The reason I wanted everybody to introduce themselves is so to know the variation of what clinical expertise people have here. We always talk about two side of the placenta. So definitely we need the OBGYN side, definitely we need the newborn side. And then so the only way we will be successful is addressing both of them. So today we're going to do the OB part, focusing on postpartum hemorrhage. But then to next week, we're going to do the newborn side, focusing on the sepsis, newborn and pediatric sepsis. So we do appreciate your time. And then without taking more time, I'm going to start. And we have half of the panelists who are going to discuss today. And then two of them are not able to come because I said work. So we know healthcare worker how it works. So thank you again, and thank you for being here. I know Miss Glory Moses is here, but you don't have a mic. So if you work on and get a mic, and then when, we can come and allow you to say hi to everybody else. But with that, I'm going to start the presentation here for a little bit. Okay. So as I said, today is May 13th, 2023. This is one of our first training for this year. We are focusing on obstetric emergencies and discussion. So we are hoping that when we have those 4 questions area, we are going to discuss, and people are sharing information from their hospital, current information from their hospital. There's no right or wrong answers. We just need to know what you practice now. And then from there, we can get those current evidence base, and then be able to come and work with people in Tanzania and be able to improve their clinical practice. So originally we had the panelists, Dr. Meza from Tanzania, Ms. Neema from Tanzania, Dr. Aminata from Tanzania, also Dr. Emma from here, and Dr. Nestori from Sweden. Unfortunately, Ms. Neema has emergency, so she has to stay with the family. And then Dr. Meza is, of course, on call doing, is an anesthesiologist, so working in the hospital, you know that part. We're supposed to have also Dr. Gwen Rand. I'm not sure if she's going to be able to make it. If she's able, then yes. Okay, so what are we going to focus today? Those 4 areas, as I said, we're just going to be the discussion. So we are going to identify how do we staging those postpartum event. So how do we know the patient is experiencing postpartum hemorrhage? Then, okay, so give them background for that part. What medication do we give, which majority of us know what medication. So this time it's going to be like, you just tell us what you are using at your hospital. And then from there, so bring back, so instead of, before the patient is experiencing postpartum hemorrhage, do we need to know how can we prepare from that? We do have what you call MUSE. This is modified early warning signs. It means like you have to identify things that the patient is experiencing, even without telling you. From your assessment, you identify those things and then start doing things to prepare for it. We have what we call rapid response. So we're going to find each country and practice what do you have in place before the patient experiences postpartum hemorrhage. What else in place that we can identify or people can follow, and then to be able to take care of this patient before she gets experiencing that severe postpartum hemorrhage. And then which ways do we communicate to notify if you're in trouble, you find your patient is in trouble, which ways do you communicate? Who do you call? Who is involved? Who is ready to go when you call them? And then how do you call them? So we're going to discuss that part so we can establish similar practice to alert each other's to make sure the right people are present on the right, on when the event happens so the patient will get the best care. And then, of course, the part that we are hoping to come and implement in Tanzania when we're doing the medical mission is quantification of the blood loss. So we all know for the OB part, when you're working with a patient who is bleeding, so the eyes can be deceiving from your clinical experience. So we need to know, are your eyes very good in estimating blood loss? Compare if you quantify it, is it telling you what exactly it is? And then are we identify early because most of the time we know everybody's like, oh, that's 500, that's 200. Yeah, and then you find that patient has clinical symptoms that indicating she's experiencing postpartum hemorrhage. So those are the 4 areas that we're going to go through and asking people to be able to share what they do currently now. And then from there, we're going to learn for future training what exactly we need to address that. So we did get all the discussion from introduction from the panelists. And of course, whoever is here as a guest, definitely if you have something to say, please share. If you have different practice or you are working, please share so we can all learn from your experience. So coming back to the first objective, we all know after the patient delivery, we call in 3rd stage of labor. And how do we manage it? From different hospitals, how do we manage it? So I am going to start with Dr. Aminata. If you can give us just a, oops, somebody's saying me. So if you can give us just a little brief that what if the patient is just delivery, and then how do you know if this patient might be experiencing postpartum hemorrhage? How do you screen them? What are the things that you go through as a doctor to try and identify if the patient is experiencing postpartum hemorrhage?
So thank you. So in our facility, in labor ward, how we can assess for PPH signs or PPH risks. So after the 3rd stage, after the active third stage of labor, as we know, we give uterotonics, we assist the delivery of the placenta with the cord traction, then massaging of the uterus, then assessing the perineum. So after that, what criteria hits us to see if this mother is onto PPH or is at risk of PPH is first the vital signs. So taking the vital signs of the mother after delivery, which is 5 to 10 minutes interval. So after delivery, the mother is taking the vital signs, assessment of the blood loss after delivery. So our labor beds have the Macintosh, so we always have the pictures on the walls to show the estimation how anybody in labor ward, even if it's the first time for that person, how to estimate the blood loss. So after estimation of the blood loss, taking the vitals, the interpretation of the vital signs, interpretation of the mother's condition, and interpretation of the blood loss. So that will show if the mother is at risk for PPH or is onto excessive blood loss after delivery, and what measures should be taken afterwards. Yeah, that's in summary of what we do and how we assess for PPH.
Thank you very much, Dr. Aminata. So I just posted there what a colleague of ours shared from Tanzania, that you guys follow the guidance. So have you seen this one before? That's what you guys use, or you different algorithm?
For us?
Yes, for you, yeah. I was just asking, because this is from Tanzania. Do you use the same or similar algorithm, or you have something different?
Literally the same.
The same, okay.
Active management of the 3rd stage, which has 3 parts.
Okay.
The uterotonic, the placenta delivery,
Mm-hmm.
and the uterine massage.
Okay. No, that's good. Thank you very much. So I'm going to ask Dr. Nestor from Sweden. Do you guys kind of follow what Dr. Aminata was talking about? Or do you do anything different from that protocol?
In Sweden, like the most of the normal delivery are done by the midwives, and they normally do the like Dr. Aminat has said, the same protocol. They do controlled contraction, and they do they are very good in estimating the weight of the blood loss and even measuring every blood loss. So they are very good in that. And we have bed sheets, but we have under the bed sheets we have another very soft tissue which cannot allow blood to go to the bed sheets. So they measure those small sheets and they quantify the amount of blood loss. So they are very good in that. And every 5 minutes they do check the uterus contraction and assess. And after 30 minutes, if the placenta has not come out yet, no delivery of the placenta, then they contact us. So we are contacted after 30 minutes if the placenta's not came out, or if the uterus is very like they have already given 10 units of oxytocin twice, and then the contraction, the uterus is not well, then they contact us. So, but the main principle is the same, like the Dr. Aminat has said.
Okay, excellent. Thank you very much for sharing, Dr. Nestor. Okay, I'm going to come back to Dr. Emma. Anything different, anything to add in how you are taking care of the third stage of labor?
No, I would say it's about the same principles. You give the uterotonics as soon as delivery has been accomplished. What we actually do here in my hospital is as soon as the anterior shoulder is out, Pitocin is running. So we don't wait for like the delivery of the whole baby and placenta. No, anterior shoulder is out, the nurse is going on with the Pitocin. Usually they will give a bolus and then they will continue to run it for a few hours, depending on the risk level of the patient. So if somebody has, if somebody is in the low risk group for postpartum hemorrhage when they came in, maybe they'll give it for like 4 hours. If they were in the medium risk, they will continue the Pitocin for about 8 hours. If they're in the high risk, they're going to continue that for about 24 hours. So they will do that. We'll definitely do the massage of the uterus and also delivery of the placenta with controlled cord traction. A lot of times the patients will have a drape underneath them, and that drape is usually calibrated. And so you can sort of see how much blood is in the drape. Of course, you'll have to account for some of it is amniotic fluid. So you kind of have to do your own subjective assessment on that. But also, if you are using any of those sponges, those can be weighed by the nurses. As you use them, the nurses will actively collect them and they will kind of weigh them and they will kind of like keep track of that. Now, if you are doing a C-section, though, we do have another option available called Triton that will actually also give you an estimate of the blood loss. They take a picture of the sponges that you've used and they use some calculations that's in that system that also incorporates the hemoglobin of the patient to give you an estimate of how much blood is there. So you kind of use a mixture of subjective assessment, but also objective assessments to come up with the estimated blood loss.
Very good. Thank you very much. From the other people who attended, any questions, anything that is not clear or any addition to that before we moved on the second part of that question? No? Okay, good. Yeah, so you can see, I mean, third stage of labor has been managed almost similar to from our part of the world. And that's what we are trying to find out to make sure, are we giving this patient similar or close to what the care should be for every single place. So if the pregnant woman show up in the US, the pregnant woman show up in Sweden or in Tanzania or Lindi, are they getting the same or similar care? So you can see majority of the process is similar and just medication or maybe give the Pitocin for the anterior shoulder. So what I'm asking, just in case if the patient does not have an IV on that third stage of labor, do you guys have done more IM versus try to start searching for IV site? Just to try and do, or are you giving standard IM Pitocin with the delivery? Because sometimes I work on a hospital, so previously with the midwife, and then they used to do like 10 units, of IM for somebody who they know is at risk. And then so as soon as the baby is born, then they give that shot, even if the patient has not exceeded 1,000 cc of blood. Have any of you guys practicing that, giving 10 IM?
Yes, we do give that, especially if the patient has come in and delivered precipitously and maybe there's been no time to get the IV going. Yes, we will sometimes do that. But the majority of people, if they have IV access, they will usually get the IV Pitocin bolus and then the continuous infusion. But yes, sometimes we have to give the IM, and it's usually 10 international units IM.
Yes. Thank you, Dr. Emma. Anybody, Aminata and Dr. Nestor, you guys have done the 10 IM? Or until?
Yes.
Oh, go ahead, sorry.
Yes, for us, it's kind of like a routine.
Oh, okay.
Yes. Even if a person has the IV, if the IV infusion was for augmentation, so for the third stage, the mother gets the shot of 10 IM, 10 international %. But for cesarean cases, they do prefer the IV infusion.
Okay. Yeah, no, definitely. If somebody's going on this C-section, they should have an IV already. But yeah, excellent point. Thank you, Dr. Minata. Dr. Nestor, the same thing, right?
Yes, we do the same thing. We give them intramuscular after, as soon as the baby is out, and then we give them intramuscular 10 international units, and then it depends. We can give IV depending on if we need to repeat but for the cesarean section patients, we give them IV.
Okay, excellent. So we usually know that the four medication also is like a phase 1 of addressing postpartum hemorrhage, and we do those Pitocin, Oxytocin, or misoprostol, Methadone, and Hemabate. And then so now I know we are using also TXA. Majority of the time, I think Tanzania, you guys use the TXA, right? And how do you administer that, the TXA?
So for
no, go ahead.
So tranexamic acid for a person with PPH, we always start with 1 gram. And then after it's the first 1 gram start. Then after 1 hour after the assessment, if the bleeding still is profuse, or the patient demands to have continuous tranexamic dose, then the person will continue with another 1 gram until the bleeding is minimal, that the person can be to 500 TDS. Yes, so we always start with 1 gram or 2 grams if it's severe PPH.
And you said you give them the IM, okay.
IV. No.
Oh, IV, okay. Dr. Emma, did you want to say something about the TXA?
Yes, we do it the same way. We will give 1 gram IV, and usually you'll mix it up with, I think, some normal saline, and you give it over like, I think 15 to 20 minutes. And then if the bleeding continues after half an hour, though, we could give another dose. So usually we will do it that way. In conjunction with, the Pitocin, the misoprostol, the Hemabate, the Methadone, the combination of all that.
Okay. Dr. Nessa, do you give IV or IM?
TXA, what do you mean? Do you mean tranexamic acid or?
Yes, yes.
Okay, we give 2 gram IV,
Maybe.
and we don't combine with the normal saline. We give just as it is, and it normally causes nausea and vomiting, and then we can give them maybe some antiemetics also in combination with that. So the patient normally has 2 large bore cannula, and the one side with the IV tranexamic acid, and the other side is the IV, maybe ring acetate or ring lactate going on like at the same time. And in combination with that, we normally give IV methalgine. This is 1.5 milligram. We can repeat about 1 milliliter, which we can repeat about 4 times. And even we can give like carboprost, also IV, which we can repeat up to 8 times. The only contraindication for methalgine is a high blood pressure and things like that. And for the carboprost, is asthmatic cases.
Okay.
And also the misoprosto as usual. And yes.
Excellent. Dr. Tia, since you work both sides of the placenta, anything on the identify those 3rd stage and medication you've done either differently or the same?
It is the same because we are following the government guideline.
Mm-hmm.
And as I was more on research part, we are also looking on the for example, when you are talking of identification, for example, measuring of the amount of blood loss, we used to estimate because we didn't have a good devices to measure the blood, but you also look on make sure that we insist to the health workers to make sure that they also control the vital signs, because a woman can bleed just a little and can go into shock because of the underlying problem which were there before. So it's not that a mass that should waste a certain amount. That's why then we can say that it's PPH. For that case, we also use vital signs to know, because if it bled just a little and you find that already there's a decompensation in the blood pressure and pulse rate, that one also we have to classify that woman as having a PPH and to be treated. But it is the same as it is in the guideline and the others have said. Thank you.
Okay, no, thank you very much. So usually, I mean, as I said, in labor and delivery, you're trying to figure out if this person is bleeding too much or too fast. And as I said, the eyes are different from individual practitioner. So what ways do you guys use to say, okay, this person needs, escalation of care? Like, okay, we need to give them all those 4 medications, give the TXA, we need to do this, or we need to grab the the NSG, put that on for the patient. What guides you to say, I need to escalate this care? We can start with anybody. Dr. Emma, what guides you to get you to know, okay, this is too much, I need to escalate this care?
Right. So I think it's a combination of subjective assessment and objective assessment. So I think you're looking at how the patient is doing. Like my colleagues have said, what are the patient's vital signs? If you are seeing that her heart rate is starting to increase, or her blood pressures, which were in the 100s over 60s, now are in the 80s over 40s, then you know that there's something going on. So that's part of what you need to observe about the patient, but also you being on the other side of the bed delivering. If it looks like it's 1,000 cc's that you've lost, that's a lot of blood. So I think you have to compare what you've experienced before in normal deliveries, like what is the usual amount. So this is where experience comes in, and what is abnormally high. So again, subjective assessment and objective assessment. If you're using a lot of these sponges to to absorb the blood, then you're probably getting into that postpartum hemorrhage range. So I think at labor and delivery, they usually give us a group of 10 sponges. And each of them, I think, roughly will absorb like 30 cc's of blood. So then if you've used 10 of them already, and now you're getting a second pack, so now you're on 600, now you're getting a third pack, now you're on 900 cc's of blood. So you kind of have to use all that information and make that assessment.
Is it in your room, do they have a scale? Like, while you are, like I said, you're throwing the sponges on the side, you realize, okay, I'm getting more than what I need. Does somebody weigh those items immediately in the room, or you collect it and then weigh later?
Actually, we usually have about 3 nurses in the room when we're having the deliveries, yes. So especially when you're using, when you start calling for like, give me more sponges, like after the first one, then usually the third nurse is now getting on that task, kind of like weighing it as you are using them and taking them from the table after you use them. So we will usually weigh them immediately, especially if you're using a lot of them. Yes.
Okay. Excellent. Thank you very much, Dr. Emma. Dr. Nestor, do you guys?
Yes.
No, you can.
Yes, I think we have just kind of the same system like Dr. Emma said. We know normally which kind of patient have high risk to have PPH before when they come to the delivery ward. Even we know their information from the antenatal clinics, so we know this patient has high risk to get PPH, maybe because of the weight estimation of the baby is big, or something else, or polyhydramnios, or something else, or past history of the delivery with high blood loss. Then we know normally that. And most of our patients are very stable. They have normal HB level, which is about 120 to maybe 140, which is maybe not the case here. I used to work in Danda. Sometimes we had a patient with HB 80 or 85. So it's all these parameters. They make us make a decision depending on all this decision. We have stable patient. We have a patient maybe with the HB before the risk factors, and we now know we are estimating maybe the blood loss after delivery, which is about maybe 600. And then if it's because of only from the uterus, or if it's because of from the perineal tear, then we can make a decision. If it's from the perineal tear and it's difficult to repair the tear at the operation, at the delivery room, then we can go to the theater to repair the tear to the theater. But sometimes it's it's very easy for us to make a decision to change from to repair a tear from a delivery room to the theater. So, and there we have a very good anesthetist that they can collaborate with us and help this patient with the fluid management and the blood management. They can take over from there, and we can focus on repairing the tear. And like Dr. Emma said, we normally have every room has a weight measurement. Every delivery room has during the second stage of labor, a midwife call another midwife. There also is 2 midwives in a room, and there is always 1 assistant nurse who is helping us even when we are doing maybe vacuum extraction and something like that. So there is 3 nurses in the room, and if in case of PPH, then they call extra help. Then there can be even maybe 4 midwives or 3 midwives, and 1 midwife is always there to do maybe the aorta compression, always aorta compression, the first key, aorta compression, and the other guys are doing the other routine measurements, like to put the 2 large bore cannulas, to put the catheter, to put things like that. So the subjective and the subjective examination of the patient, like we see the patient now, the vital signs, the Muse control, the vital signs are not stable, the BP is down, the pulse rate is high, we estimate also the bleeding. We are up to 1 liter bleeding, and we are there still at the delivery room. Then we make a decision. Maybe we have to go further to the theater so that we can put apart from the medication, where maybe we have already repeated methalgine maybe twice or 3 times, and the bleeding is not under control, then we make a quick decision to go to the theater where we can have much help, and maybe the patient is relaxed, and we can do the procedure in peacefully, comparing when we are at the theater, at the delivery room with a family member, partner, and the baby, and things like that.
Thank you very much, Dr. Nestor. Mr. Branco, you raise your hand?
Yeah, I think someone posted a comment relevant to this topic in the discussion.
Kuruthum, she said, vital sign, can you guide us, and the physical assessment of the patient? Yeah, thank you very much, yeah, Kuruthum, yeah, agreed. So that's why we're trying to find out things that will clue or alert us to say, okay, you need to speed it up, or you need to pick up the speed, or you need to ask you for help. And that's what we are discussing right now. So there is a standard way of doing those things by having protocols in place, or there's other experience. If somebody who is experienced there, they know for sure this person is going to bleed. Yes, we use those factors that, okay, this patient is being predisposed to, they're going to bleed. As Dr. Nestor is saying, increased fluid, polyhydramnios, so diabetic or bigger babies, preeclampsia or placenta, whatever. So all those factors, yes, can lead us to say, we can anticipate this patient is going to get in trouble. However, we need to be able to pick up the speed and say what else is going to happen. Dr. Aminata, I'm going to give you a chance. What things usually drives you to escalate care if you think this person is going to get in trouble?
So the maternity team in our facility, we always put much effort on preventing first the PPH. So after assessing the risk of PPH to a mother, if the risks are high according to the mother's condition or the fetus condition, we always, the third stage of labor, the active management of third stage of labor is always followed by the preventional prophylactic treatment. So is anticipated to have PPH, for example, for preeclamptic mothers, for IFD deliveries. So the patient enters into labor with misoprostol as adjunctive now of the oxytocin that is given. So misoprostol, 1,000 microgram tranexamic acid, the 1 gram should be there, and X much of the blood that may be needed. We always start with preparing ourselves for those patients which we anticipate. So we don't wait for the PPH to give tranexamic or misoprostol. We give them prior, or with that also, we also give IV infusion of oxytocin for those patients. So if the PPH happens, as I said earlier, the assessment of the vital signs, the assessment of a senior now, because the assessment of the blood loss, if PPH is diagnosed, the senior person in the labor ward is consulted. So we have a routine to have a medical doctor in labor ward. So after, if for example a nurse or a midwifery has delivered the mother, so when she just get the instinct, or she diagnosed the PPH, she consults the medical doctor. So the medical doctor assesses the mother. So any further assessment, that will be needed, a senior person is consulted. If it's a senior medical doctor in the department, or if the specialist is available at present, is consulted. So as other colleagues have said, the vital signs interpretation is a key. Then reduction of further hemorrhage is also a key. So if we assess and find the cause of the PPH, if it's atony, then as a protocol for PPH, 3 people needs to stand at the patient. So one at the uterus, the other one at the IV infusions, if giving drugs and all that, and another one to trace for blood products and for drugs and all that. And so if the team is assembled already and the cause is identified, so the cause is sorted now. If it's trauma, the patient is examined where the trauma is. If it's something that could be repaired at the labor ward, then it's repaired there with local anesthesia. If it's something that is so extensive like the posterior perineal tears or cervical tear, then the mother is taken for EUA, for anesthesia for that repair. And if the cause is atony, so those measures of massaging, compressing the uterus, giving uterotonics and all that, they are taken. If it doesn't subside, then the mother is taken for theater to look for other causes. If the atony is probably due to uterine rupture or due to placenta creta or something retained that has not been removed manually at labor ward, then the mother is taken for theater assessment. Yes. And for coagulopathy issues, we always in our facility we can get the ward blood. We don't have packed RBCs currently, so we can get ward blood, we can get FFPs. So if we query this PPH is due to coagulopathy issues, and the mother is still bleeding regardless of the with a contracted uterus, so we hold the uterus, the manual uterine compression continues. If it's putting the tamponade and getting the FFP, then consulting for a fast referral for a facility which the mother can get the mother can get like platelets concentrates, because currently we don't have platelet concentrates, and currently we don't do in our facility coagulopathy studies. So if we ascertain for coagulopathy issues, we do such measures and act for a fast referral, so that the mother can get such products that will need at a particular time. Yes, so that's in a nutshell of what we do.
Thank you very much, Dr. Minata. Yes, so I mean, I can understand that you might have a protocol already you're following, so that's great because you can see the sequence of things that people need to escalate care. Yes, Dr. Emma, in fact, I was coming back to you and I'm glad you're raising your hand. Go ahead.
Yes, I was going to say that Dr. Aminata has made some very good points.
I know.
Yes, I was like, yes. So especially when it comes to, okay, so what if the uterotonics are not working? Then you definitely have to broaden your mind and think about it. Okay, what else could be causing the heavy bleeding? Trauma, does she have some tears which are still bleeding? And I think that's a big one. And I think if your patient has, for example, epidural anesthesia, it really helps a lot because you can really do a good exam, get in there, identify what's bleeding and take care of it. I find it, however, more challenging for patients who come in and maybe have refused to get any anesthesia from the get-go. So then, they're in pain and you're trying to get in there and see what's going on. So then you may need to call for anesthesia to come in, and maybe even she may get some IV pain medication, something like a narcotic, like, I don't know, like fentanyl, that will just kind of make them more comfortable, and you could do a good exam to determine the extent of the tears. Tissue, yeah, you want to check the placenta. Is your placenta intact? Did all of it come out? Or is some of it left inside her? So you might want to have an ultrasound at the bedside and do a quick scan and see how the inner lining looks like. And then thrombin, that's the other thing. I always remember it. We call it the 4 T's. when it comes to postpartum hemorrhage. So the first one is torn, is the uterus well contracted? 2, is there any kind of trauma? Are there any tears that you want to fix? And then 3, tissue, is there any retained placenta? 4, thrombin, does the mom have some coagulopathy going on? So usually I would order the coagulation tests if I think the patient is in what we call stage 2 of the postpartum hemorrhage. So if they have bled more than 1,000 cc's, and now you can see that the vital signs are becoming abnormal, the heart rate is going up, the blood pressure is going down, that's when I would usually order the coagulation, the PT, PTT, INR, fibrinogen even. But if they're still in the stage 1 where, okay, they have 1,000 cc's, but the vitals are still stable, maybe I won't necessarily order it at that point. And then the other things that you want to consider, which also Dr. Aminata talked about, is was there any problems like placenta previa, placenta accreta that could also be causing the heavy bleeding? So I would say, back to answer your question, Dr. Harriet, about when do you actually escalate things? I would say if we're in the stage 2 of the postpartum hemorrhage, where the blood loss is more than 1,000 and ongoing, and the patient's vital signs are unstable, then I would tell my nurse to activate the code hemorrhage, we call it. And so that's when she gets on the phone and she, announces to the unit that we have a big problem, we need help. Everybody that needs to be there needs to come in. And we will have the hemorrhage team that comes in that's comprised of different people, including anesthesia. We have the charge nurses coming in. We have more help from the nurses. We have the blood bank people being alerted. At that point, we're already ordering, 2 units of blood to begin with. So that's when we would usually escalate everything.
Yeah, excellent. And thank you very much for all the OB/GYNs who gave us the scenario of how your typical day when you're addressing or you are anticipating or you're identifying the postpartum hemorrhage event is about to occur or has started or is in progress. So I share that slide there because usually they try to standardize the care that if Dr. Emma shows up and take care of this patient, the same thing should happen when Dr. Aminata shows up or Dr. Nestor shows up or Dr. Tilia shows up. So that's why you always have to ask for protocols. So you might have an excellent physician or midwife at the bedside. So we want to make sure the patients will get the best care possible and equal care possible, regardless of which doctor or which midwife is there or which nurse is there. So that's why we always try to make sure, do people have protocols? That's something that can help standardize that care. So we'll be able to provide same care, same time, and for every single patient. So that's, from your discussion, I can gather that you guys have standing protocols, which thank you for having that, because that creates a consistency between the patient care, because pregnant patient is going to bleed so fast and so quickly. Before you think about it, she might lose her life. So, and we know from Tanzania statistic, I believe one of them, I think it was the World Health Organization, 1997, they were saying that postpartum hemorrhage in Tanzania specifically was close to 47% of patients who is experiencing the postpartum hemorrhage. So that's almost half of the people who, if we misdiagnose or mis-screening them to know that they're going to be at a risk, they might end up losing their life. So that is a huge number. And even if you lose one mom, that's too much. But almost for the 7% of people who are experiencing postpartum hemorrhage might end up losing their life. That is too much. So that's why we're having this discussion. And I'm so excited that to hear all the protocol things that you do at the delivery as the patient is experiencing this bleeding. So I'm going to go to the next slide.
I'm sorry, I just want to second what you said, Dr. Harriet, that this can quickly turn, as we call it here, south. Like it could go the wrong way. If you think about it, the blood flow to the uterus in a woman at that stage, I think they quote up to like 500 ml per minute. And so if you're having somebody that's bleeding from the uterus, and if you take the average woman has about, 6 liters of blood, I mean, if you're playing around, within 15 minutes, you could lose a woman right in front of you. So we do have to act quickly. And it's wonderful to have these protocols that help to guide everybody.
Yes, thank you, Dr. Emma. So that led me to the next slide, which you're saying we have to create consistency. And that's why I asked that question, how do you anticipate, how do you escalate it? So we have to have things that prompt us. So let's say you guys experience, great. So I'm brand new physician, midwife, nurse. I need to know, to have something to guide me. What do I know? I need to start calling for help. So we have those MIUs, which is called modified early warnings. So this is something that clues us. Okay, if the patient is dropping their blood pressure by this percentage, if the patient is start giving you this clinical finding, okay, we need to ask for help. So I know every single one of you have discussed about seeing those deterioration of the vital signs. You're getting those clues, you have your assessment before. So that part is already covered, I think, and I believe all of you have practiced that part. So now we get to the next part, which I know Dr. Emma and Dr. Aminata mentioned, that you guys, you already have people in mind when you're trying to call them. And I think Dr. Nestor also did mention that they have the doctors and 3 nurses in the room. So yes, so now you see these things has already passed stage 3 of the postpartum hemorrhage, means the patient is losing close to 1,500 or more than 1,500. Patient is deteriorating fast. Now, who do you call? So if you can just go and we started with Dr. Aminata, tell me that we call for help now. We call maybe this doctor, this nurse, this anesthesia, this part. So we know like your team, emergency team or hemorrhage team has how many people are coming in there. There's no right and wrong. There's no right numbers or something that just we can discuss to have a standard that the bare minimum you can have maybe is 5, bare minimum you can have 7. We just need that number. Are we practicing that? Maybe or maybe not, because of staffing, we know that part, but we just want something that if it's evidence-based and you're practicing currently, give us who are you gonna call and how do you call them to make sure they come there immediately. Dr. Aminata, I'm gonna start with you.
Thank you. So literally use the call for help term. So when you diagnose the PPH, literally where you just shout for help. So in our labor ward, at least we always have four midwifery at a session, at least 4, with 1 doctor. So with that, if you shout for help, the people around you first will come to rescue, or will come to help you with the scenario. Then, as I said earlier, if it needs further assessment, then other people who are not next to you or who are far may be consulted. So we can use phone calls to alert the people who are far, for example, the specialists who might be in another ward or who might be in their offices. So after the phone calls, if we get the response after the assessment of the specialist, if there is any multidisciplinary approach that may be needed, then phone calls are always used. In our labor ward, we do have a phone. We do have an official phone there. So it has like the numbers, the contacts of people who may be required at any time in the labor ward, or also in theater if there's any emergency. So after the specialist, we may need an anesthesiologist or anesthetic to come in, so they are always called at the place. We may need a person from the laboratory. Sometimes you may have some difficulties in getting the blood products and all that. So if you have a chief in the lab or somebody who is so responsible there, so you may get faster response compared to go manually to the lab. So we always use phone calls and just shout alerts And when to call, we call when any one of the team has the instinct that this is PPH. So anyone in the team, PPH in our labor ward or PPH in theater is not a one-man army thing. So when you just diagnose it becomes a teamwork issue. So after the assembly of the team, each person will be given the role to play in that team. Yes, I guess how we do.
No, thank you very much, Dr. Aminata. That great overview. So my question to you is that, so you said you make phone calls, which is great. So do you mean like there's somebody has been set aside that, let's say a nurse, whatever, or an intern one who's going to start calling list of the people? Or is it like you call one phone call and then these multiple people are alerted?
Literally what we do is you call the specific person.
Okay.
First. So there's always a roster on board at the bar and theater. So any person will be alerted that we need a specialist. We'll see into who is the specialist on duty, who will be available. Specialist on duty is available at the particular time, should be available in the facility. Yeah. So, and the numbers are displayed in the roster, below the roster. So any person who will be given the role to call the person, like call the specialist on duty, will just go to the roster and look who is on duty, call the number. If he's not available, there's always a next person who is available at the facility, because it's just like all cadres should be available at the present. Yes. Okay. So after the call, we need to have a leader. Now, if the specialist is there, then he will be the team leader. He will lead us to this. So we'll be calling at and according to what we will need at the particular time. Yes.
Okay. Thank you. Dr. Nestor? How do you notify?
Yes, hello.
Yeah.
Yes.
How do you notify the provider needed or the disciplines needed to come and help you in the emergency of postpartum hemorrhage?
PPH. Yes. We like I said, we because in my hospital, at my hospital, we have 3 delivery wards, so we have four doctors on call if it's night shift. So there is normally 2 specialists, obstetrician, and 2 residents, no interns at our hospital.
Okay.
And every hospital in Sweden, in gynecological department and obstetric, there's no interns. So there's residents and there's a specialist. Very few interns, and if it's interns, maybe they are rotating one month and they are not on call. So I normally team with another doctor, so I have his number always in my work telephone, so I can call directly if I know that I have a bleeding which is about 2 liter now, or 1.5 liter, and the bleeding is not under control. So I call my partner, and then we come together and make it decision together in a room. And there's already maybe 3 midwives and one and maybe other colleagues. And if we make the decision to go to the theater, then there's always our anesthesiologist take over the other management. We are focusing on maybe if we repairing the tear or focusing on stopping the atonic bleeding. But the anesthesiologist is always responsible for the bleeding, for the blood substitution, for the fluid substitution, and they are always in contact with the hematology team. So we are not much involved when to come to how much to give. But like I said, our patients, most of them are very stable. They even can handle about 1.5 liter loss without even substituting them blood, most of them. So we normally don't give blood up to maybe 2 liters. And when they are at the postnatal ward, then we can give them blood if they have HB, which are around 8 or maybe less than that, and they have symptoms. But normally 1.5, they normally manage without even substituting them blood. So this protocol about if they have more than 1.5 liter bleeding, giving them 2 international units, it doesn't work at our center. But if the bleeding is up to 2 to 3 liters, then you can give them as much erythrocytes component or red blood cell component as possible. And if the bleeding is more than that, then they always give maybe 4 red blood cell, 4 plasma, and they give you thrombocyte concentration. There is also this 4 and these rules. So they normally very aware about that, and we are not even doctors. We are not even involved in thinking about which product to give. So we are normally focusing on maybe repairing the tear, maybe controlling the atonic bleeding. So, and sometimes if it's very, very emergency, like if the woman gets maybe heart attack, then there is alarm that you can, if you just pick the telephone and call. So everyone in the house is involved, who is involved is automatically informed. So you don't have to call anybody else. So you pick that telephone, or a nurse pick that telephone and give you a feedback. I have already informed. So everyone come to the theater room, and the team assemble, and they do everyone know what to do. So that's the way we contact each other. And like I said, and if there's, like I said, for the first time, if I call my partner, and if we need like another support, we can call another, we call it like, we have 4 doctors at the house, and one which is this maybe super specialty, or the professor at the house at home. So we call him if we need him also. But normally it is we are already 4 at the house.
Excellent. Thank you very much, Dr. Nestor. So I have a couple of questions for you. So I do agree when you say the 4 and 4s, so those are usually we put on the criteria of like massive transfusion, because that's the time you activate that call, and then they know anesthesia usually takes over, and they know how much the patient needs to get, what type of the as you said, the supplements and all those stuff needs to be done by anesthesia. I agree with you. My question I have is, you said, for example, you're working with a partner, so you call the partner. So you are calling the partner, that's fine. So remember the other people who are working with you, the nurses, the other doctors who are there, before the patient gets to the heart attack, as you said, or cardiac arrest. So who is going to decide, okay, nurse so-and-so call this person, nurse so-and-so call the lab, or call the blood bank or something? Who is deciding the part?
It's automatically me as a maybe first on call at that delivery ward. I'm the one who is deciding. But sometimes if it's a resident who is like in the first months of his rotation, so a senior nurse or midwife, a senior midwife can take that position to be a leader and call the other team.
Okay,
yes.
Cool. Thank you very much. Okay, I'm gonna
thank you.
Oh, sorry, go ahead. Oh, Dr. Nestor.
I'm done. I was like finishing my sentence.
Okay, thank you.
Thank you.
Okay, Dr. M, I'm gonna let you answer the same thing. Who do you call, and how do you call them, and how soon can they get there?
Thank you. Yes, so I do agree with what the others say, that you need your team to manage this. This is not your one person army to manage this. So what usually happens in my hospital is if we think that the patient is in stage 2 of the hemorrhage, and that's when the EBL is at more than 1,000, and now the vital signs are looking abnormal, then anybody can activate it. Usually if the nurse is there at the bedside and the attending is not there yet, the nurse can do that. But you as the attending physician, if you're physically there, or the midwife, you could also do that. And we have a great system because everybody who works at the hospital, who is a nurse or a doctor, they have this thing called Vocera, which is like a little phone system that they have attached to their scrubs. And it is hands-free. You just attach it to the top of your scrubs or your pocket. Hands-free, voice activated. So what the nurse can do, or you could just tell the nurse, can you activate the cord hemorrhage? And what she will do is she will, I think, have to call the emergency operator, and then she'll say something like, emergency operator, and then the emergency operator comes on, and she will say something like, cord hemorrhage, room 212, labor and delivery unit. And then that will trigger the Vocera system to reach out to everybody who is in the postpartum hemorrhage team. So the anesthesiologist, the blood bank, the charge nurse, all of them have their Voceras on them. So they will get an alert, cord hemorrhage, this room, and they will, move to the room that's involved. And the team itself is pretty big. If you look at the list of the people who are in the postpartum hemorrhage, I counted about 12 people that are listed down. And that includes the anesthesia team. So that's the OB anesthesia doc, the OB CRNA. They have the NICU team. I guess if the baby is still not delivered, they will have the charge nurses coming in from the labor and delivery unit, but also from the postpartum floor. They will also come in. They have the respiratory therapists coming in, the phlebotomy people, in case you need more IV access, blood bank, we have the pharmacy, and also we have the chaplain that also gets notified in these types of situations. So I think we have a good system because we don't have to make any calls. You just speak into that Vocera and things get activated.
Thank you very much, Dr. Emma. I think that's similar to what the hospitals, majority of the hospital here in the US. And that's the reason I was asking that when you call, who needs to make the decision to call and who is actually making the phone call? Because remember, that's an event, an emergency event. Everybody's doing their work, like with that stress, with that tension. So there's very easy to forget to call the right person to the event. So if you make individual calls, there's a chance you might be missing somebody. And that's what I was asking. But from your discussion, you've already identified people who are already on the call, people who could be coming to the event like that, but that's fine. But usually we have to find a way that it should be that everybody feed into one phone call. If I make this phone call, all these 7 people are getting this call. Because remember, we discussed that the pregnant patient or postpartum mom can lose their life very quickly. And when someone that started bleeding, and the bleeding can be so severe very quickly, and we don't have 5-10 minutes to wait for somebody to come in. And that's why majority of the hospitals here, they do have what they call like those code alerts or code notifications. So our hospital, for example, have OB alert. So if OB alert, if the patient meets this criteria, if you're calling them, maybe the pregnant patient who might require C-section, they have code prolapse. So that could be OB alert or OB start. OB start means like we are running. The patient is running to the C-section. And then so when you say the OB alert or OB start, when you press that button, has almost 7-8 people listed in there. I don't have to call anybody else. Everybody has the little number. They need to alert them, and then we meet in the OR. So we don't have to make a more phone call, which I understand if there's, for Tanzania, if you have ways of notifying and people are already identified, that's just to make sure we tighten that process and make sure everybody knows if the event happens, okay, this person is going to make the first phone call. Like Dr. Nestor said, yeah, he's the one who's not making the decision. Great. So he said, make a decision. Okay, I need all the hemorrhage team. So somebody needs to be physically and do calling and make sure you don't miss anybody else. I think Dr. Minata said it's written on the roster. Great. So if you have the place that is identified, every single person who works in that delivery room or has to know what those numbers are, and they need to call. So it has to be on the one phone, one information like, okay, call or be emergency or something, and then continue taking care of the patient. Because remember, if you are in charge and you start ordering people around and stuff, so who is actually doing the resuscitation of that patient? So we have to shorten that time so we can use the minimum time to address the calling people there. So the rest of the time we can be saving this mom's life. So thank you very much for that discussion. And we can continue having this conversation to make sure we standardize and make sure the call system becomes more efficient. It should not be like somebody you call and maybe somebody doesn't have the phone call, because the cell phone, yes, they're very good, or the calling system are very good if it's working or somebody logged in. But if we have a way of notifying people without even calling individual numbers, that they just get a 411 or 911, whatever you decide, that could be an option also to try and alert people to come to the event versus start calling and explaining yourself, oh, I have this patient, because that's not the time to start giving the report. If I need you here, I need you here now. And I want you to come and help me versus me doing over and over the same thing. So excellent discussion, guys. I
wanted only to add one point on that.
Yes, go ahead, Dr. Nestor.
Yes, I think Dr. Emma, it's very interesting to hear that you have this like hemorrhage team, but we at our hospital we have this we can call an alert like when it's like we have a heart attack, when we have like we want to do like a very emergency cesarean section, when we suspect like a brush placenta or uterus rupture, something like that. Then we don't have to call any single person. We just pick up one telephone, and I can delegate to someone else. I can delegate to midwife, nurse, assistant nurse to do that, and she has to do, or he has to give me a feedback. We have already done this. So everybody meet at a one point. We meet at a theater. So we have that one also, but it's not in every, like for hemorrhage, we don't have specific one. What we can do is, like I said, is we use the same system like Dr. Aminata said. I call my partner, and then we make another decision to call someone else. And at the same time, there's a lot of person in a room, and which one person can stay as a leader, and which can delegate everything. But it's very interesting to hear that you have this one that you can call you can just, even for the hemorrhage. That's very interesting to hear. Thank you.
Yeah, you're welcome. It's great. And I just wanted to add that we have that code for the hemorrhage. And like I said, that's for when they're in stage 2. Now, if they're in stage 3 of the hemorrhage, you are actually now calling for massive transfusion protocol. So you're saying MTP code, and that will activate the massive transfusion. So we do have the option of the hemorrhage code or the MTP code, and it works great. It's very, very helpful.
That's very good.
I do agree with Dr. Emma. That's the same thing also for our hospitals here. They do have specific teams. And then so as nurses, when you show up in the unit, you are assigned already, okay, you're going to be the first responder, the first scriber. So when we call the code, you know you are raw. And then so you run. And as I said, you have those little notification, and then you go. So most of the time, the nurses don't like make individual call, unless it's somebody who was not in that group, and maybe you're calling of the surgeon. Maybe let's say a patient had the abdominal surgery, now she's pregnant, she's going to have a C-section or vaginal delivery, but that person who was not even on an OB team, then somebody might make an extra phone call. That's the only time it will happen. But most of the time, for emergency purposes, you just initiate one phone call, or you do in the room, hit the button, and everybody is within the hospital department there knows that is an emergency. Or you call on their phone, and then everybody gets a notification. So it's something that if it's feasible for Tanzania or any other part of the country or the globe, it's something nice to have to minimize the time of calling individual people. Because as I said, when an emergency, you are about to lose this patient, and you don't have time, as Dr. Nestor said, okay, you notify somebody else. Yes, somebody needs to take over the wheel and continue. You focus on that patient. So hopefully that person also has that sense of urgency. Quickly go and start calling people immediately, not saying, oh, I called doctor, so I can't find them. No, we don't have that. We need to have somebody. That urgency has to be there, because we need that person's expertise to come and help. And it's good to have this discussion, so you know somewhere where we can improve, and then ask for assistance if possible. Sharing for protocols, it would be nice to know, okay, which team has how many people. We might not be able maybe to satisfy, like Dr. Emma said, we might have 10, 12 people. Not every hospital can afford that, but if we have the bare necessary, minimum people we can have to save this woman's life, definitely we should have that opportunity to be able to prepare for that. So great discussion there. Do we have any questions from the audience or participants there, please, about that part?
Yes, I just want to also add that every now and then we will actually have practice sessions of everything. So I guess we call them like simulations, where they will kind of like imagine a situation where this postpartum hemorrhage with like a dummy, and like you all practice how to do that. So usually the residents and the people who are at the hospital will kind of do that. If you happen to be there as a private attending, you can also participate. But I think going through such situations in advance also helps, because then you can check and make sure that whoever needs to have that vocera is actually connected and getting them, and they know what to do in that type of situation. So I think simulations also helps a lot.
No, I agree, Dr. Emma. So definitely that's an area that to know for sure if everybody has the current number and the number works. So then in the emergencies, because when you call, remember there's no follow-up phone call. So if you call and you're supposed to be there attending, or the person in charge, and you did not get that call, maybe the phone died or the phone, the number has been changed because whatever the issue is, and then you didn't, the log was not updated, so the emergency call comes and you don't get it, then you're going to be in trouble, because you might get there and the surgeon is not there. You want to do C-section, the person who is supposed to do surgery is not there, so that is not a good thing at all. So definitely you have to have those drills, like quarterly drills, to be able to call and see whoever is required to be there responds to it and say, okay, good. So we know for sure next time when the patient is experiencing severe postpartum hemorrhage, then when we call, every necessary person is required to be there, should be there. Dr. Aminata, do you have anything to add there, or if have an experience that has happened and you guys have, how did you manage it to make sure that patient has been addressed?
Well, it's a challenge, but I think it's just a technological issue that hinders us to reach there. But we had a complicated case that once complicated because of these calling issues, like people who were called were not available at the moment, so a complication happened. But the that set and is prepared to be practiced, of using a bell, a button that when you have it, it will alert the responsible people. It's just like what you do, but it's not as automatic as how it is already there. So we had a plan that we can use a button that can ring to the places that the responsible people are always present. For example, there's a specialist room, and if that bell, if you ring that button, if you click that button, it will ring a bell into that office, or it will ring a bell into the laboratory office. The bell will shout for PPH in labor ward, for example. So that was a plan that was arranged to be set as to minimize this process of calling a person one by one. So it's in our plan. Yes, for sure, it's a shortcoming process, because it takes a lot of time, as you can call this person and don't get a response, call the other, unreachable, call the other. So it's most of the time it also demands a manual approach, like you go, you run for somebody who is not reachable. So I think it's technology issue, but I think using the bell we can start with that, then it will progress to these automatic alerts, like how you guys have reached now. Thank you.
No, thank you very much. I appreciate that. But then definitely, in fact, it was now I was answering my next question is so having the like one system to try and provide those notification does help. And if you do the drills or mock drills to see, like you simulate the actual event, who is going to be there, how long do they take to get there? Because that's also determining, like next time, if the decision has been made by the doctor, like what Dr. Nestor say, from that decision to go to the OR and save that patient's life, how long it will take? Because that also counts the patient's life. Because if we realize that the patient is bleeding so much, we don't have that much time. And then the person who is coming to do and help us with the procedures on the emergency doesn't get there until 10 minutes. That is a long time. And therefore, if you call that person and is not there, you have to find the second person. That's an added time that we don't have and the patient does not have. So definitely I agree with Dr. Minata. I mean, like even having the bell in the unit, if that process or program start, that will help at least to alert people there's an emergency event. And if you know that you are needed, even if they did not call you, you show up and then let them send you away. Because when they call that means the patient require help right now. So if you're doing routine work, I think the routine work can wait and go and save somebody's life and go lay hands to see if you are needed to try and help that patient. So I think that's the work in progress. We can continue discussing those things. There are some things that we might have or suggest that may not require maybe this fancy technology, but just the basic things like pages or something like that. And then it's something that can be implemented and to try and see, can we have, even if it's not like something that you have to talk about, it is just like the page that you wear in a system and then just call and see if it will work that way. So there's something that we can try and discuss and see if it will help, but having the bell in the unit, at least that will create awareness and people will be able to respond. They'll stop whatever they're doing to like, okay, what's going on? And that's what you were asking. So then they know, okay, it's labor and delivery. And of course that we start with when the patient comes in. That's why I put that maternal fetal triage index. When the patient comes in, we need to screen them and see how potential they are to bleed. And if we know this person, when she delivers, we are going to be on a high alert. So then from the beginning, even if the person maybe you might call later, you alert them, you know what, I have maybe 35-week or 37-weeker who has high blood pressure, who has A, B, C, D. She's still in labor, 2 centimeters, 5 centimeters, whatever she is. And then when she delivers, we might have to intervene because she has all these risk factors. So that person maybe will stay close by versus not knowing exactly what is going in labor and delivery. So then, of course, they go on their way. And then by the time you call them, either they forgot the phone in the office or they went to get something to eat or whatever. So, but it's something that we need to get more practice, alerting people ahead of time. We have this potential in labor and delivery. And we know sometimes you might alert them today and then the patient does not deliver until tomorrow. We know that. But at least more information will help and then minimize that notification time and then to try and improve the patient's safety. One of the things that if you have any severe event like that, always make sure we have documentation. So documentation means like how we have to document and then you use it as a learning tool for next event. So if there's something, let's say like Dr. Minata say, we call and then they're not there, you call, then they're not there. So that time, somebody has to be able to say, we call at 12 o'clock, and by the time we get the help was 12:15. So how can we shorten that to 12 to maybe less than next time 12:10 or maybe 12:05? So then that unusually it increase, it benefits for the patient. So knowing those things, we have to have a documentation. If you don't have a documentation, it's becoming just a story. Oh yeah, that's what we did last time. Oh yeah, we had the same thing last week or 2 months ago. So it becomes almost a habit of the delay because you don't address it. But if you put it in a paper and then you can follow it up and then go do the restarts. We call and then the first incision was 20 minutes. Okay, so maybe we need to address these things and shorten that part. Next time we call the decision to incision is 10 minutes. Okay, great. So we are getting better at that way. And that's how we improve the things along the way. So to make sure every single physician or midwife who is taking care of this patient, and then they get into this situation, if they alert somebody else, then the first intervention is going to be happening, emergency intervention is going to be happening within 8 minutes. So it becomes a gold standard of every person who is taking care of those patient in labor. And that's how you create patient safety. So we're going to continue doing those discussion and share our findings. And of course, we need you guys to share what you do now. So then if there's something that we can help address it, then we should be able to, and we're working together. So we are all trying to make sure we save this patient's life. Okay, so the next one is just the documentation. Usually you should have something like, then you're going to debrief, especially for those emergency situations. So did we do a resuscitation? Did you do the IV? Do we do it? So this is just a documentation, not necessarily that you can use. It's something that we have to create specific for specific hospital first, practice it, and then make it better. So this is just an example. We don't need to go over it. Okay, so the last thing we're going to discuss is, we already discussed part of it, estimation versus quantification. We do know as healthcare workers, our eyes are different. The more you see blood, you get desensitized about the amount of blood. And especially if maybe one patient came and bled so much, but still they're doing very well clinically, they're doing very well. Yes, the amount is too much. Then we get like, okay, so if that one patient can do, then that's okay, should be okay. But we have to make it objective. And that's why we're trying to push for that quantification of blood loss. Yes, it's a little extra work to do it, but also it's the tool that we can use to save the patient's life quickly and on determining or escalating the care before it gets too late. So I know, Dr. Nestor, I'm going to start with you. You did say that you guys usually weigh the pads and stuff. And then have you used that, have you experienced any situation that maybe visually you say, oh, this was, okay, could be 500, it could be 800. And then when you weigh it, you find out it's already past 1,000. Or vice versa. You say, oh my, this is so much blood, and then you weigh, you find out, oh, maybe it's not that much. Have you experienced anything like that, Dr. Nestor?
Yes, I think sometimes you, Nema, yes, I have experienced that, but not very often, because I'm here with my doctor, so yeah. So sorry, Nema.
Future would be.
Yes, I have experienced that, especially during the theater. Sometimes they say, okay, we think it's 100 cc, and then when you put it in a weigh machine, and then it's about 150, and then so we normally recommend to measure. We have these machines everywhere. We have this at the labor ward, and we have this at the theater. So we use this machine everywhere. So I think we are normally very good in estimating the amount of blood loss. Yes, and like you said, it's if you just look like this, it can be maybe difficult to. And we are very good also during the cesarean section to differentiate. Now we are not counting the amniotic fluid. Now we are counting the blood. So now the amniotic fluid is over. So now we are counting the blood. So because everything is going in the same jug or some, yeah. Yes.
No, excellent. Thank you very much. Dr. Emma?
Yes, I just want to say that Nema is also one of my favorite names in the world. I have a daughter called Nema too.
Nice.
Yes.
Yeah, very nice.
I love that name, yes. But I was going to say that I think in general, I think the studies show that we tend to underestimate when the bleeding is a lot, just subjectively. And I do believe we do the opposite. We tend to we underestimate when the bleeding is a lot, and when the bleeding is normal, we tend to overestimate. That's what the studies show. So I think it's great to have the objective options available. So like I said, we usually have a machine that will weigh the sponges, and then you could do the calculation of how much EBL has happened based on what is the dry specimen weight. And also the drapes, like I said, do have some calibration that you can use. But also just subjectively, like I said, if I can see that the peripad is fully stocked, usually I'll estimate at least 300 cc, like that figure shows.
Excellent, thank you. Dr. Aminata?
So for us, we don't have a weighing machine for estimating the blood loss. We just use a subjective way. We carry in our labor ward, we have the sterile cotton that is available in the set of delivery. So we use that to estimate like for one bundle we have the 50 mils for one bundle, because we do use the small bundles of gauzes. So 50 mils. So you calculate to the bundles that you have used after delivery. And we also have the Macintosh that is used for the mother to avoid the escape of blood into other places. Macintosh also we are trained to use it according to the size of it. So if you see the stain of the Macintosh, like this much equals to 300 mils, this much 500 mils, this much 1,000. That's how we do. And in severe cases, like in PPH, that happens during cesarean section, when we use these suction machines. So we use both sterile gauzes that have been used, estimation of the blood loss, plus the blood that had been sucked in the suction machine. So we literally just use the subjective ways, yes, of estimating the blood loss.
Thank you very much, Dr. Aminata. So that is the reason that we discussing today, because I agree with Dr. Aminata that you have that, and you have the ways that you can say, okay, in one bowl of the cotton is 50 cc. So that's the part that you see for the people have a gauge to see it. But as I say, still, if I say saturated because I see blood every day, and somebody else says saturated because they don't see that much blood, so our estimation is way going to be different. And then, so that's why we're trying to find ways of making it consistent. But I agree, if you don't have a weigh scale to try and get the weight of the soaked pad, it's going to be hard to get that accurate weight. But it's a baby step. So if we have a guide of like, okay, so this is what we have, and then if you see a picture look like that, then yes. But unfortunately, the companies that are making these pads or the checks, like the bottom pads, they're doing a very, very good job of making blood being soaked through it and create a little sheet of dry, so the patient does not get wet. But the problem with that part, and so hinders our eyes to estimate correctly. And that's the problem comes because you feel like, okay, no, it's not, looks like it's soaked very well. Maybe that patient is going to be, so you're going to underestimate that part. And that's why I think there's a literature support that sometimes also we worry, like, okay, I don't want to activate postpartum hemorrhage protocol because you have to give those medication, you have to watch it. And so people are like, okay, no, because the patient doesn't have clinical finding. So chances is that might be less. So it might be 300, especially like vaginal delivery, or it might be 250. Because sometimes you see the number is always consistent, 250 delivery. I'm like, I don't think 2 pregnant women will have exactly estimated blood loss. But to avoid all those complications or delay on the identification of the patient at risk for postpartum hemorrhage, then we have to wait. So Dr. Aminata, then yes, part of our goal in this medical mission, we are coming, we're going to try to work with you guys to do the quantification, and we're trying to, like raise some money here to try and buy those little scales. So when we come with work you guys to try and see the difference, your estimations and the actual weighing of the blood, then how close is it? And some people are very good in guessing the amount, which is fine. But we're trying to make it standardized that if you are there and the next provider comes in and the next provider comes in, we are all having a correct amount of blood loss from this patient, so we can actively or escalate the care as needed. So that's the part of our medical mission this time, and that's why we're doing the talk today, to try and find these similarities or things that we can work together or collaborate to make sure we improve the identification of the blood loss for these pregnant women. And we know we can easily lose this mom. Sometimes it's unnecessary, because if we screen them, identify them, and prepare for them, so then even if they come in and deliver, even if they lose 1,500 So, but if we put the measures in place, 2 bowls, blood product or medication, and everybody's ready to go, so chances is that we're going to spare them their life, and that's the goal. We want to make sure they go home to raise those kids they have. So, and that's the music to the ears of the all the OBs and the neon groups. So the next slide is like, so how do you know? And I know Dr. Emma did mention a little bit about comparing the weight with the dry items. So here, for example, in our hospital, we have things that we commonly use in the labor and delivery. And then, so we do the dry weight first. And then, of course, because we're using this electronic system, so that dry weight is already inputted in the computer. So if I weigh the Qhsc, for example, that's the little bottom pad. If I weigh that and it give me 200 grams. So if I put that 200 grams, it's going to minus 135. So then we know for sure whatever is left is 65. That's the blood loss on that pad. So we have those things in place just because we were able to do it. So for example, for Tanzania, if you don't have the electronic system, so then we have to work with putting it on the, like on the log, and then we try to work. These are the common standard, but yes, people bring their kangas, so we have to probably find basic, the lighter and heavier vitenges. So if they give us at least for a few minutes to weigh and make sure, and then we give them back to them when they clean it up, that's fine. So those are things that we can try and address it, because our goal is just to identify the patient who is at the most risk of bleeding to potential getting more complications. So I'm going to ask Dr. Aminata, have you thought of ways of like to quantify, even if you don't have the scale right now, have you used other ways other than using the cotton balls for estimation? What happened to the blood that goes on the patient's kangas or vitenges? What do you do with that? Because most of the time, I mean, at one of the hospital, when we came to Tanzania, the patient had their own kangas already still in bed, and they were delivering with that part. So of course it was soaked. And then, so how do you estimate that way?
One of the things that we use, as I said earlier, is the Macintosh.
Okay.
We emphasize more the use of Macintosh instead of the kangas, because the kangas differs with how much the kanga handle can add. Some kangas are less have less cotton compared to others. So we emphasize more using the Macintosh. And when we are out of the Macintoshes now, when the mother has to use her kanga, then we literally use the subjective way of obtaining the blood loss. If the kanga is fully soaked, fully, and it's not that it doesn't have that much cotton, then we estimate it as 800 mils. If it's a thick kanga that is full of cotton and is fully soaked, it's one liter. Yeah. Or if there's some blood spilled on the floor, so the assessment is just subjective, but if it troubles you to assess it, then another person, the senior person, is called to assist you. But the value that is always taken, we agreed on one another that the highest value should be, it's better to overestimate instead of underestimating. Yes. So it's better to see if you overestimate, like say this is perhaps the EBL is 1.5. It's better to do that and give blood instead of underestimating and following the sequela of hypotension and shock and all that later. So the highest value is always taken is always taken.
No, excellent. That's, you stole my points, because that's what I was going to say. Usually, if you're using the estimation process, definitely, yeah, the higher the number, that's why the one you want to use for management, so to prevent the patient from getting more complications. So thank you very much. So for here, you used to use the little scale, like you can see it. It's just something that you weigh and then you zero it and you weigh and put it stuff. So that I think that we can practice while we're there and then see how we can work and continue with that part. Dr. Nestor, anything to talk about the quantification and the items that you use in labor and delivery? Are they always consistent for all the patients, or what happens if patient brings something that is not on your list?
I think I can share both my experience of working in Danda Mission Hospital and in Sweden.
Mm-hmm.
In Sweden, we are relying much on the weighing scale and the weight measurement. We are using that everywhere. So we are very poor in estimating blood loss using the Muse control. We are very poor in assessing. Okay, now we have systolic blood pressure around 70. We should have blood loss about 2 liters now, or we have a heart rate about 240. We have to maybe around 2 liters. We are very poor in that now, but we are only using the weight measurement, and yes, sometimes we are using the vital sign, but mostly the weight measurement. And we are using, we are using, like I said, the above the bed sheet, we have this sheet that it cannot avoid. It can just prevent the blood from penetrating the bed sheet. So all of these are measured, so we know their actual weight, and we know when they are soaked with blood. So that's very easy to differentiate, and we change them regularly during the procedure when we have a PPH case. So we can change them as soon as possible. We see that they are full and measure them. Like the assistant nurse is responsible to measure this sheet every time. So, and now it give us feedback. Now we are about maybe 700 milliliter, and now we are about this one. Now we are about 1 liter. So we get this ongoing information every 5, maybe every 2 minutes. So mostly we have the weight measurement. Like I said, every delivery room has a weight measurement, and every sheet that on the woman delivery bed measured, we know their weight. And we know their actual weight, their dry weight, and then we know when they are soaked. Because we put them there and just make a subtraction.
Excellent. Thank you very much, Dr. Nestor. So, Dr. Emma, anything with the weighing that?
Sorry, I just wanted to just say my last words, because I'm just on the way to Ndanda now. Soon I will just start driving to Ndanda. So I wanted to thank you all for this wonderful work you are doing. And I wanted to add also very few points which I have just noticed and I've experienced. Dr. Emma said about this simulation every cases. We are at my hospital in Sweden. We are doing this very regular. Every new resident has to do at least 1 to 2 simulation, and the simulation is like, which cases are we talking about? We are talking about heart attack. We are talking about massive postpartum hemorrhage. We are talking about eclampsia, preeclampsia. All these cases we are simulating every maybe 1 to 2 times a remedial and a new medium. And the other thing is we normally do a discussion every time we encounter a difficult case. Like, not only a difficult case, any case that even if it's not very difficult, but we think it's very challenging, we think the communication didn't work during the helping this patient, then both midwives, nurses, doctors sit together and discuss. So this is not like once a week. This is every day when you are working at labor ward. And we have every day, sometime not, but maybe at least 3 times a week, you have to sit and discuss, okay, we had this case, what did we do better? What did we do good? What do we need to improve? So this is very important, because we can forget easily when we are not discussing these things. And like I said, I worked in Ndanda before. We missed this. We didn't discuss a lot, but I don't know now. But my last time I was there for 2 years ago, the discussion about, okay, we have this kind of patient, to discuss and give each other feedbacks. You did good in this area, you did good in that area, keep it up, and then we can do better in this area next time. And we can even give feedback to the people who referred the patient, because in the problem here in our setting in Tanzania is people come from dispensaries with massive complication after PPH, which is not possible in Sweden, because in Gothenburg, it's about 1 million people. We have only one delivery hospital and no private hospital. Everybody come there in that region, and everybody come to there to that about, yeah. So everybody come there, and we are about 150 doctors. So I have been there for about 3 years. I've never seen any maternal mortality death. Comparing to Ndanda, I have been in Ndanda and I've seen maybe per year in Ndanda, I've seen maybe 15 or more. So this is, I think, okay, even these small steps, they are not very economical demanding. They don't demand a lot of knowledge. They demand a lot of discipline to follow these small procedures to improve maternal health.
No,
so
definitely.
that is yeah.
No, thank you very much, Dr. Nestor, and for your contribution and for the summary. In fact, you carry us to the end with a summary that things a takeaway from this discussion. Yeah, little small steps, yeah, little identification, notification, those things will save lives. And then so that's what we're trying to do, a little contribution on those areas. So I'm gonna let if the participant, anybody has any question before the panelists start giving their final words. Any questions, something that you did not know, you learned, or something that is not clear? Please, anybody? Kuruthum, do you have anything to say? No? Dr. Msambichaka, anything?
No, I just keep learning a lot every time I attend these sessions. Thank you for a very robust discussion.
Thank you for coming. Anything else? We're gonna probably try to finish it up. So just the goal, as I said, for this meeting was to share best practices and then learn from each other, share those protocols and stuff so we can improve our care every day. And we have great expertise here to come and share their experiences and the clinical practice. And then so I'm gonna let Dr. Emma, oh, there she is. Yeah, Dr. Emma share her findings, and then I'm going to have Dr. Minata help us close it. Dr. Emma, anything we learned, anything you want people to take away?
Yes. I just want to say again, thank you for organizing these sessions. I think they're very helpful for everybody. You know, I think it's very helpful to know where we are at. All the different providers at different countries, kind of seeing what they're doing, and then learning from that as far as like knowing what to make better for the specific situation. So I think it's very helpful. I think the bottom line for me, like protocols are a key thing. Protocols really make a big difference because it helps to standardize care for all patients. Assuming that the protocols have researched like what what is the best practice or what is the best approach in these types of situations. And every protocol will be different for each situation. So I think a modification has to be made for a particular place, depending on the resources that are available over there, as far as human resources, but also the materials resources. I cannot expect the protocol that I use in my hospital here in the USA to work to the T to a situation like in a hospital in the rural Tanzania area. So I think we have to make modifications for that. And I think that the last takeaway for me is really just streamlining everything, making it less work for the people involved, I think makes a big difference. So like, why should you have to make a phone call to somebody to tell them to come and help you having a postpartum hemorrhage? There has to be an easier way, a faster way of getting that help when you need it. So I think focusing on that is also a key thing. So thank you all for sharing all the information that you've shared. And I want to applaud the doctors in Tanzania on the ground, doing what you do with the limited resources that you have. It's not easy, but I think your clinical assessments are key, and it's helping a lot. Thank you, everybody.
Thank you, Dr. Emma. Dr. Aminata, if you can help us close. Any final say, anything that you think we should be doing?
Having this session, for hosting us, and I thank you for sharing us, sharing me and my colleagues, because I'll just pass everything that I've learned in here to them. So as how Dr. Emma said, like, protocol is key. And I think even in our facilities, though we have less resources, but majority of the key things are doable, and we just need to amend some things and just bring those simple things that can work with us. So thank you, and I hope to learn more in the next sessions. And thank you for having us.
Yeah, thank you very much. Before I forget, next week we have the neonatal and pediatric sepsis, and we're going to send the invite so people can sign up. But I just want to say thank you specifically to Dr. Minata for sharing your clinical experience from your hospital, and that's how we learn and know what we need to work on. As an organization, we try to collaborate with countries, different countries and different practice, but we want to make sure we help our families and friends at home and make sure the providers have what they need to be able to provide care. Like Dr. Emma, I'm going to echo what she said. Even if you guys have limited resources, you are doing an excellent job. You have all those protocols that needed to be able to take care of the patient or standardize the care of the patient. So all we need is just, as you said yourself, just tightening up the little places to make sure we take care of the moms, and then of course we have all the providers provide the same care. So with that, if nobody has anything to say, I want to thank everybody who came in today and share part of your Saturday with us. But we all want to save at least one life. So by doing that, we equip healthcare workers with all the tools they need to take care of their patients. And then if we can help in any way, God willing, definitely we do it. And as I said, we are planning quite a bit of things to do in this September when we come to Tanzania. We're going to continue talking to people who were here today and finalize a few things, and then we'll get to Tanzania at least we can continue the discussion and improve the care. So thank you again for everybody being here. I'm Dr. Harriet Gabone and Qhsc saying thank you for coming. Have a great Saturday and the rest of the weekend, guys.
Thank you.
Okay, bye.
Bye. Thank you.
You're welcome.